Hello everyone. So this is a brief talk about the 9th edition of Neonatal Resuscitation Program. The book will come in November, so please look forward to it. So I'm just going to present the changes that are done in 9th edition as compared to the 8th edition. Of course, all the presentation, this is adopted from the American Academy of Pediatrics and American Heart Association. So I will highly advise you guys to refer to the NRP textbook. Like I said, the book will be launched, in November. So now let's start. So this is the, as you guys remember, 11 lessons, are there. So 5 new lessons are added, and we are going to talk about it later on. So this is just a snippet of the addition, the supplemental lessons. And as you guys remember, there are 2 parts of provider course. One is the essentials and the other one is advanced. So it still remain the same. So those who are dealing with a newborn nursery and labor and delivery, and if they don't want to do the advanced course, that's fine. But the whole course should be followed up as the NRP provider, those who want to do the advanced NRP. So what are the changes? I have characterized it into different subjects, so that way is easy to remember. But of course, when the new book is launched, we have to go through the book, and there are nice videos also available on the AAP website. The skill video, I will highly advise that one who is going through the provider course should watch those videos, because that gives a real insight to the procedures and the practice sessions. So anyway, so let's do terminology. So what happened now in the 9th edition, that they added the birth and cord management plan, and we are going to talk more in detail about the cord management plan. They have removed suction from the initial part. If you guys remember earlier, we have to provide suction, warmth, of course take care of the temperature, then dry, stimulate, and and then there was a suction thing there. So now you don't have to do suction if the baby is vigorous, crying. There is no need to suck the baby, and so suction is being eliminated. Another terminology, the positive pressure ventilation, has now been simplified to just ventilation. So that way is easy. So these are the 3 terminological changes. Now, what about cord management? Those who work in L&D or labor and delivery, and they know that now the notion that if the baby has no problem, it's a term baby, the obstetrician usually defer the cord clamping, and they wait for 60 seconds, which is 1 minute. And the science behind it is that the placental transfusion is very important for the babies, and there's a lot of literature on that. And this talk is not tailored towards the benefits of cord deferred cord clamping. The basic idea is just to tell you what are the changes. So one is deferred clamping, the other one is milking. Milking is entirely different, where you really milk the cord from the placental side to the baby side 4 times. And like I said, there are video available on the AAP site. Please do watch that. So anyway, going back to the cord management, 2 changes have been established. So deferred cord clamping, as I said, that now it's 60 seconds for infants who do not require any immediate resuscitation. And so this could be delayed for 60 seconds. And again, remember, if there is abruption placenta, avulsion of the cord, or any acute scenario, of course, you can easily, take the baby and clamp the cord right away. But we are just talking about babies, and most of the babies will fall in this category where they do not require any immediate resuscitation. The other option is the umbilical cord milking for those babies who are not vigorous. So this is the second category, and again they have divided into 3 gestational age epoch or the the ranges. So just remember that if the baby is 35 to 42 weeks and is non-vigorous, they can do the milking, because the cord, deferred cord clamping is not the option here, and they want to give the baby to the neonatologist or the the staff of NRP they are waiting. So one category. The other category is 28 to 34 weeks. And again, this, like I said, if baby is non-vigorous, there is not enough evidence to recommend that milking is going to help. And the third category is premature babies, extremely premature babies, those who are less than 28 weeks, we should not do the milking. So again, easy to remember, milking is not recommended for extremely low birth weight, extremely premature babies between 28 and 34 is again not much evidence. So basically, if the baby is 35, late preterm and post-term term babies, you can do the milking even in a non-vigorous baby. So the next change is in the oxygen. So the target oxygenation saturation table has been changed now. So it will start at 2 minutes instead of 1 minute. The rationale is that the first minute of life, the team is busy in stabilizing the baby, the newborn infant, plus the putting the sat monitor, counting the heart rate might take some time, and that's why they want to start at 2 minutes. But the targets are the same as in the previous one. The only thing, the table has been changed now. Just remember that. The second thing about oxygen is the concentration range. So if the infant is greater than 35 weeks, you can do 21%. Between 32 to 34, you can do between 21 to 30. And less than 32, you can do the 30%. So easy to remember. If the baby is less than 32, start 30, and you can go up accordingly. And so just remember this chart. So here it is, the saturation table. As you guys can see that now it's starting at 2 minutes, and it's a 65 to 70, and then the oxygen saturation improves with time as expected. And so this is the table you guys should follow. About the FiO2 or oxygen concentration, for late pretermer and bigger babies, you can start with 21%. For babies between 32 and 34, you can do 21 to 30%. And if this infant is less than 32 weeks, you can start with greater than 30%. So that's the change in the oxygen target and oxygen and FiO2. So in ventilation, I have divided this into 4 or 5 slides so that you guys can understand. So in ventilation, the pressure, so they have increased from, if you guys remember earlier, 20 was the highest PIP, the peak inspiratory pressure or inflation pressure. Now it's 25, and they have given you the range. For bigger babies, you can start higher. For smaller babies, you still have to go with the 20 to 25 centimeter of water. The second section in ventilation, that we usually, we used to do 40 to 60 breaths, but now they are recommending 30 to 60 breaths per minute. So that will change the way you use the TP resuscitator or the way you ventilate. So if you guys remember, breathe 1, 2, 3, breathe 1, 2, 3. So that has to be changed a little bit. We'll see how the book will describe that, but this is, you have to remember that the rate target or the rate ventilation rate has been changed. The other thing in ventilation is the corrective steps. You guys remember the mnemonic Mr. SOPA. So mask readjustment, reposition, and then all that. But now what they are recommending, that instead of just after 15 seconds, give some time. So you have up to 30 seconds before you start corrective steps. So you have to wait 30 seconds and then start the corrective step. And now what they are saying, you don't have to do in an order like M, R, S, O, P, A. You see whatever, is the clinical scenario, and then you can do whatever you like. Suppose you can, suction the baby's mouth and then right away go to increase the pressure, or you can even apply airway earlier than going through all the stuff. But this is again to remember that Mr. SOPA still holds good, but the only thing, the order in which we perform, you can change according to whatever is the clinical scenario. So you don't have to follow M, R, S, O, P in this order. So I hope this makes sense. The last part in ventilation is that now laryngeal mask may be used as a primary device, and now you can so you don't have to intubate if with an airway anomaly or a difficult intubation. One can use laryngeal mask as a primary device. And of course, like we know that smaller masks, laryngeal mask, airway are not available, so we have to see how things will develop. But for now, we know that this could be used as a primary device. In intubation, there are 3 changes basically. So instead of using the word tip to lip, now we are going to use tip to the upper gum, which is the maxilla. You have to use that. And now the weight based has been changed, which I'm going to show in the next slide. And now it's highly recommended that the infant is less than 800 gram. You can consider the smaller tube, which size 2. So this is again the first box talk about the tip to gum instead of tip to lip. And these are the table, it has changed. So for 800 gram and less and 22 to 25, you can consider size 2, and rest of the thing is in the table. So just so this is a change now. So you just have to remember this, put it on your neonatal resuscitation room, and or an ICU, because now the new book will have resuscitation outside the delivery room. So we have to know the resuscitation in NICU plus resuscitation outside the hospital. There are 2 new chapters that are being added as a supplement. So again, to summarize, what are the changes? So as you see, the birth has been added and the initial cord management plan has been added in the new edition. Of course, the initial part remains this, here you can see the antenatal counseling and all that. The question remains the same: term gestation, good tone, breathing or crying. If that's the case, then you go ahead with this box. If that's not the case, of course, you go ahead, dry, position, stimulate, and you see that they have removed the suction. And again, this remains the same. The only thing you have to remember now, if the baby does not have any labored breathing but still have persistent cyanosis, you should think of cardiac problem. And this is a very nice course. Has been offered and is available now on the NRP side. Please, I will highly advocate that you guys log into that course. And there is another presentation we have on our YouTube channel. It's describing briefly what this course is all about. So I will highly recommend that you guys should do that course or take that course. Again, we have already talked about it, that saturation target has been changed. It will start at 2 minutes instead of 1 minute, and the rest of the things almost the same, as it was earlier. Only thing, like laryngeal mask, as we talk about, you can consider as a primary device. So again, to summarize, like we talked about already, that oxygen target has been changing, and this is the new table according to gestational age. So just remember that. And again, to reiterate that new NRP cardiac course is now available. And as you guys can see, that supplemental lessons has delivery out, the outside the delivery room resuscitation is being going to be discussed, which I think is very important, because currently now the NRP was totally on the delivery room, but we know that things can change. A nursery baby could have the need for resuscitation, or NICU, like here you can see that the resuscitation plus the NRP needs will be there outside the hospital, especially for our EMS staff. They have to know the basics of NRP, and rest of the chapters are there. And like I said, this congenital heart, if you do this module, you will learn better about the congenital heart. So like I said, this basically all about the new changes. And again, if you are logging in for cardiac course, please do this Science in Science course. This basically walk you through what I just walked you through, but it's a very nice way of doing it. It's a self-learning. So once you watch this video, it's all summarized there. I think you can just go ahead and do that. And this is all available on the NRP site. So I hope you guys have learned something together today. Please do like and subscribe to our channel, and I wish you all the best with the new course. And for question, please do comment on this site, and have a wonderful day. Bye.